Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you all for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this podcast, we're talking with an expert ENT surgeon on mid-facial pain. Well, for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Approximately 1 in 10 adults will experience pain or discomfort in a mid-facial distribution. This is more commonly described amongst females and young adults. Understandably, most patients with mid-facial pain believe their sinuses must be the cause of the pain, as the sinuses lie within the face. Nasal endoscopy and CT scanning, however, has shown that chronic sinus infections are not such a common cause of facial pain. It's unusual for sinusitis to cause significant discomfort without also causing thick nasal drainage, a loss of smell and or nasal obstruction. And in such cases, some drainage or inflammation is seen on nasal endoscopy. More facial pain caused by sinusitis, however, is usually relieved at least in part by a course of antibiotics. So once excluded, non-sinus causes of facial pain need considering. These may include 1. Tension headache reflected in the face and felt as a pressure or tightness across the bridge of the nose, forehead or back of the head. The face may feel swollen and the nose may feel blocked, but there's no actual obstruction to breathing. There is commonly tenderness over the forehead and cheeks. The pain is typically relieved by a low dose of amitriptyline, 10 to 25 milligrams daily, taken at night for 6 weeks. 2. Migraine headaches, more common in women with a family history and typically lasting up to 48 hours. Nausea is a frequent associate and nasal congestion is not uncommon. Anti-migraine medications such as sumatriptan, 50 milligrams daily, may be used acutely. For frequent episodes, pozotafen or amitriptyline may prevent recurrence. 3. Cluster headache, which may cause quite severe unilateral pain around the forehead, eye and or cheek. A little more common in men, may last over 1 hour, and typically the eye and nose water on the side of the pain. Management is as per migraine. 4. Temporomandibular joint dysfunction, facial pain caused by temporomandibular joint dysfunction. And this is an inflammation around the jaw joints and may respond to rest and simple analgesia. And 5, neurologic pain like trigeminal neuralgia, postherpetic neuralgia, or glossopharyngeal neuralgia, which is usually severe and burning in description and may have a trigger point. A response to medication such as gabapentin is desired. Well, Dr. Andrew Martin is here to educate us further. He's a practicing ENT surgeon in the southeastern suburbs of Melbourne and northern Tasmania. He completed his MBBS at the University of Queensland in 2008 after a Bachelor of Pharmacy Sciences with honours from Monash University in 2003. He also completed his fellowship with the Royal College of Surgeons in otolaryngology and head of neck surgery in New Zealand in 2021 and completed an advanced fellowship in head and neck surgery at the Royal Melbourne Hospital in 2022. He has special interests in nasal obstruction, obstructive sleep apnea, ear and balance problems, chronic sinus disease and mid-facial pain, pediatric ENT, as well as swallow, voice and throat disorders. Andrew is also a busy family man with 2 young daughters and enjoys hunting and fishing. So it was a great privilege to have this conversation with him, exploring the syndrome of mid-facial pain in more detail. Please welcome Andrew to the podcast. Now, Andrew, welcome back. We're going to talk about mid-facial pain. We've talked about sinusitis, we've talked about rhinitis, and some of those problems you've already mentioned do present with a degree of mid-facial pain plus other clinical symptoms. Tell us about mid-facial pain. How do we approach that diagnosis of mid-facial pain? Tell us all about it.
So during my training, I would get these patients who would come to me with just a massive shopping list of problems. And your heart would sink and you'd think, oh, God, don't bring up another, throat issue. Oh, now I've got to look at that. And over time, I started to join the dots that these people presented as a cluster. So typically these patients will come in complaining of either facial pain or ear pain. And then on top of that, they'll complain of things that sound seemingly completely unrelated. They'll complain of a sore throat when they wake up in the morning, a dry mouth. They'll complain of snoring as witnessed by their partner, and they'll complain of severe fatigue. And so you sort of, as a group of GPs where those clusters of symptoms lead, you're thinking, okay, they've got facial pain. It sounds like they've got sleep apnea. They've got a dry mouth. and they seem to complain of ill-defined things like phlegm. I'll take a little diversion here on the topic of when people talk about things like phlegm. You'll hear everyone using terms like catarrh, which I think is a little bit antiquated, but they'll also talk about mucus or throat clearing. Like, what are they talking about? And similar to that, these people will often complain of postnasal drip. Now, you've got to stress that these symptoms are subjective. They're not objective, unless you can put a scope down there and actually see something dripping down the throat. So there's a subjective sense of postnasal drip. There's a sense of thick mucus. And I say to everyone, go for a run around the block, and you'll often find you have to mouth breathe. And you'll get this build-up of mucus in your throat, and you've got to clear it and spit it out. And there's a reason for that. And often when you draw the dots together with these patients, they have a tendency towards nocturnal mouth breathing. They're often people that are not troubled by a blocked nose so much during the daytime. But when they lie down flat, they feel their nose starting to block up. And so they have to kind of open their mouth to breathe. They wake up in the morning with symptoms which you could attribute to mouth breathing, including a dry mouth, because your nose humidifies air, right? And thickened mucus. Now, often it's older people that complain about this because their baseline salivation has been reduced. They've got atrophy of the salivary glands. And you see this in radiation. People who've had head and neck radiation have very thick, tenacious secretions. And for whatever reason, it seems that the salivary glands' basal output of serous output seems to vary a lot, but the mucus output doesn't seem to be as significantly affected. So what I think happens is that their salivation drops off, and then the saliva becomes more mucoid in consistency. And because they're overall got a dry throat, they become more aware of the saliva in their throat, and they call it phlegm. And it's not. And 99% of the time, these people will have had a CT scan because someone thinks they've got sinusitis.
Yes.
CT sinus completely clear.
Yes.
And they may have even been treated for reflux, and often, and there is an association with reflux, and we can talk about that. But often even then, they may still be, throat clearing. And I think a lot of it is that they have a baseline low salivation rate, and then top it off, they've now got nasal obstruction on top of that, which is dynamic and related to their posture because of venous congestion. So then they're mouth breathing, and then they're presenting with thickened secretions in the throat, and so they feel the need to clear it, and then they tell you about their throat clearing, and some of them even dramatically will bring in like a little cup, and they're like, I want to show you this to your doctor, have a look. Like, that just looks like your spit. But thank you very much for showing. I don't know if you can familiarise.
I do know this patient, and it is very distressing for them actually, and also for their partner, because they're clearing the throat all the time. It can lead to a degree of let's call it marital disharmony at times.
Yeah, and you often wonder where you can probe your nose when there's these sort of marital issues. Like you'll find couples that refuse to sleep in different beds, and they're like, but if it's that disturbing, do you sleep? Why not just sleep?
What's your approach? I'm fascinated. What's your approach to management? I don't think I've managed these patients very well, but I like that explanation you've given.
I feel, Luke, we're on the brink of evidence-based medicine here. I don't think there's a lot of strong evidence, if we're really very honest about it. A lot of this, I feel, is my own clinical impression of these patients, but there is some evidence, and we'll explain that. But I think that you couple the mouth breathing with the hyposalivation, so they have aerodigestive symptoms. They have sinonasal symptoms in that they complain of a blocked nose.
Yes.
And then on top of that, they complain of midfacial pain. And you could think, midfacial pain, blocked nose, that sounds like sinusitis. But the rest of the symptoms are mainly aerodigestive.
Yes.
They're complaining of a dry throat, thickened mucus, subjective postnasal drip. And I think it's just they're aware of this thickened saliva at the back of their throat. And then they often tell you they have ear pain. And you ask about other ear symptoms such as hearing loss, vertigo, tinnitus, pulsatile tinnitus, which is an awareness of your own heartbeat, and they have none of those symptoms. They don't have any other ear symptoms. And then you give them a good old hoik on the TMJ and they go, ow! They always jump off the bed very dramatically. Well, don't push so hard, doctor. Like, I didn't push that hard, sorry. And then what's very interesting, because there is some evidence in chronic pain literature of this concept of central sensitization. Where the internal map for pain means that you get referred pain on one half of the face. Now, this sounds like bogus and something alternative, but there's actually fairly good evidence for this. And so when you palpate the infraorbital neural foramen and the supratrochlear neural foramen, both of which are trigeminal in origin and therefore share the same sensation as the temporomandibular joint, and so you palpate their STN and their ION, and they're markedly tender in those locations. But it's sometimes bilateral. Yeah, you often find there's a hemifacial distribution in the pain, and I don't think it's some strange, trigger points or something like that. I think it's just simply that these neural foramen are trigeminal in origin. Your TMJ is predominantly trigeminal sensation, and so because they've got significant pain in the distribution of the TMJ, then they develop associated pain on the same nerve distribution side. And if you're not sure about TMJ pain, what I do is just put a glove in and then palpate the coronoid process. Yeah, so you're going intraorally, feel the buccal mucosa, go back, and then you can feel the TMJ intraorally, and you just palpate there, and they'll be even more tender there than they are if you palpate externally. You landmark externally, you feel your zygomatic ridge, which is just your cheekbone, and you just stick your finger below that and about 2 finger breadths in front of your ear canal, and then that's your TMJ. And you get them to open their mouth like that, and you give them a good firm push. And the investigations for TMJ dysfunction, I think, are notoriously unhelpful. I've seen people get MRI of the TMJ, and you might see a little bit of wear and tear, but I don't think it's any imaging is very sensitive for diagnosing irritation. I think it's predominantly a clinical diagnosis.
So are you saying that sort of mid-facial pain we're talking about, that's associated with, sort of the sensation of blocked nose, the mouth breathing, the sensation of mucus because we're maybe getting poor production of salivary enzymes and so forth? Is that mid-facial pain? That's a trigeminal nerve pain that we're getting. It's all part of this sort of syndrome.
I believe so, yeah. Look, if you look up the pain literature on mid-facial pain, you'll see a lot of disparate diagnoses, such as atypical facial pain, mid-facial pain. In fact, I'm struggling to remember all the labels, but there's a bunch of diagnostic labels that people use, and the predominant cause is referred pain from the TMJ. I think there are other causes of mid-facial pain. Obviously, there'll be things like dental problems. There'll be even atypical migraines, that sort of thing. There's even a very uncommon condition we see in ENT, which is a controversial diagnosis called Sluder's neuralgia, and that's pain in the mid-face caused by abutment of a septal spur against the lateral wall of the nose. And it presents with severe But that's a canary, yeah. And I believe I've seen one case of it because she presented with severe headaches from a nosebleed due to clots trapped between the septal spur and the lateral wall, and it disappeared when I put a numbing pack between the two, which is the classic. But I'll absolutely agree with you. It's a canary, yeah. But I'd say day to day in an average clinic of, let's say, 25 people, I'll probably see 2 or 3 that match this constellation of symptoms.
So it's unilateral.
Unilateral, usually unilateral, not always. Sometimes they've got bilateral TMJ dysfunction. And I think what's going on is they lie down to sleep at night. They've got a blocked nose. They've got a mouth open position.
Okay.
They have...
tension in the joint.
Yeah, so they have a mobile TMJ. they develop bruxism,
Right.
which is a nocturnal behaviour you can't control, hence TMJ pain, hence referred pain within the distribution of the trigeminal nerve. They have other associated symptoms of mouth breathing, such as dry secretions, etc. And they often have sleep apnea. Now, I don't know whether it's the chicken or the egg, whether the sleep apnea is driving the mouth breathing, or whether the mouth breathing is really just a result of nasal congestion, and that's worsening the sleep apnea. But they often have sleep apnea, and they have symptoms of sleep apnea. They feel knackered when they wake up in the morning, and they've often got partner witnessed snoring. So it's very interesting.
It's a fascinating complex, and it sounds like it's more common, certainly in what you're describing in your clinic than I had appreciated. What is your approach to management? How do we best tackle that fascinating complex of problems? How do we best approach that?
Yeah, 100%. So look, the first thing is to exclude alternative diagnoses. I think it's reasonable to do a CT of the sinuses just to say, look, this is not actually sinus disease. This is midfacial pain syndrome. Second thing, I always think, what did the patient come in with? Typically, they come in with a constellation of symptoms and not one significant complaint of nasal obstruction. So I'm not going to waitlist these people for surgery right off the bat to fix their septum, for example. Most of the time, I'm going to start them, take a sort of a two-pronged approach by, number one, improving their nose as best as possible without surgery. And number two, doing what I can to reduce their aerodigestive symptoms.
Right. Okay.
So I'm going to start everyone on a dual nasal steroid antihistamine combination, typically third generation antihistamine. Like good product is either Dymista or Rialtris, and those combos have got a nasal steroid, which is pretty much just Nasonex, and a third generation antihistamine, which is proven to be effective against vasomotor rhinitis. And then on top of that, I put them on sinus rinsing. And see, sinus rinsing, what that does is washes all the mucus, all the allergens out of the nose. Right. And then I talk people how to apply. So you always do your left hand to the right, right to the left, and so you angle the spray laterally to hit the turbinates and the sinus area. And I explain to patients that you're not going to get benefit for about 6 weeks. On top of that, I start them typically on Gaviscon. I mean, there's very weak evidence for Gaviscon. And look, you know this way better than I do, Luke. But there's this sort of concept of non-acid reflux. And you've got things like pepsin, haven't you? And so we're sort of covering that with Gaviscon in case some of their symptoms are due to reflux. And then I refer them for a sleep study, especially if they're presenting with symptoms of snoring and fatigue, because I want to confirm that they've got OSA. Because if they do have severe OSA and go on a CPAP machine, then they're going to get hydrated air that's coming into their nose. That'll get rid of a lot of their feelings of dry throat, etc., in the morning, and the thickened mucus, etc. And by correcting their nasal congestion and their OSA simultaneously, the idea is that you get rid of that mouth open position, which is driving the TMJ dysfunction, but also the nocturnal bruxism, which is a feature of OSA, to reduce the TMJ-related pain. Now, like a lot of complex things, I think you can hit it at different points along the pathway. So you could try, for people who don't want all of that, you could try low-dose tricyclic antidepressant like amitriptyline, just for low-grade chronic pain. And the other thing I always think about is sending them to a specialist dentist who can make a mandibular splint. To be clear, unless they have OSA, you don't want a mandibular advancement splint. But if it's just a matter of bruxism and they don't have OSA in their sleep study, I'll still recommend, if they've got a lot of grinding and a lot of bruxism, go to a dentist, get a custom-made splint, which just creates an interface between the teeth. And I think a lot of the pain results from the teeth jarring against each other in that sudden releasing movement. So a dental splint should help with that.
I'd like to thank you all for joining me on the conversation with Andrew on the midfacial pain syndrome. It certainly opened my eyes up to this syndrome, and I gained valuable insights into how to recognise it and manage it. I hope these insights have been shared with you all. Next week, we'll be covering a wide range of topics across many specialty interests. The discussions aren't intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed, and may be emailed to manager@gihealth.com.au.